In the Situation Room each and every weekday morning is Ndu Oko, CT Muga, and Eric Latif. Let's switch the conversation now from one pandemic to the other pandemic, the global pandemic that's COVID 19. And there are people who are saying the real pandemic is actually our health sector, Kenya's ailing healthcare system. Right? We have talked about this. So, what exactly is happening in our health sector? The COVID 19 pandemic has exposed a lot, like you said. A lot of things have happened since that time when COVID was declared in the country on the 13th of March, Friday, 13th of March, 2020. Huh?
Yeah, but it's just the thing is, I think, unfortunately, COVID has been blamed for the occurrence of these things.
Yeah.
I think the only blame that should be given to COVID is the exposure of a lot of things that had been happening anyway. Either they had been covered up by the powers that be, or those who were then operationalizing them kept them quite quiet. But then everything came to a standstill. And it's kind of like when a child is coughing during the day, you don't really feel that they're suffering any malaise. But then when the sun goes down, things get worse. So in this case, you have a depressed situation. There's really no activity. And that's when you get to see the rot that really lies therein. Now, Afia House, been called Mafia House for the longest time, right? But then as a result of some of the things then that were not dancing out in front of us, we got to see that there was quite a lot that was going wrong, that had been going wrong, and did not start with COVID. And I'm not going to be one of those who say, well, COVID has caused this and that's why it happened. I'm the one who says, because COVID created a depressed situation, then you were able to actually see what was really happening on the underbelly. And it needs some action, needs to sort out those wrongs.
Let's have this conversation with somebody who is part of a group that are going with the hashtag The Real Pandemic. She's Lisa Owino, advocate of the High Court and program associate for health governance at the Kenya Legal and Ethical Issues Network, KELIN. Lisa, good morning to you.
Good morning.
Welcome to the Situation Room. We're glad to have you.
Thank you. Pleasure to be here.
So you'll shortly tell us about hashtag The Real Pandemic. First, tell us about KELIN. What is this organization and what do you do?
Okay, KELIN is an independent health rights NGO. So basically, we advocate for full implementation of the right to health. Do this in a number of ways. So advocating for the integration of, constitutional principles, human rights principles within laws and policies that relate to health. We also facilitate access to justice for people who have faced health-related human rights violations, participate in strategic litigation for issues, that could affect or are currently affecting the right to health. Yeah, so we do this in multiple areas: sexual and reproductive health and rights, HIV, TB, and health and governance, which I am affiliated with or I guess connected to.
Right.
Yeah.
And now, The Real Pandemic. Why hashtag The Real Pandemic?
So hashtag The Real Pandemic is sort of a recognition of the fact that the issues that are plaguing the health sector aren't, the COVID pandemic didn't come and destroy Kenya's health system. There were already so many pre-existing issues. The constant lack of transparency and accountability, incredible number of corruption cases, as I've just had you refer to, the way we've referred to Afia House as Mafia House for the longest time. So that strain, that trend of, corruption, lack of accountability for corrupt institutions or individuals implicated within corruption scandals, the lack of follow-up, transparency, even financing. Kenya has made regional commitments for how much of its national budget it ought to allocate to financing, and yet we have never reached even half of what Kenya has committed to. And so that strain or that trend of things, that trend of violations isn't new. It's merely exacerbated by the pandemic, because times of crisis, we all know, during times of crisis, there's a lot more opportunity, there's a lot more gaps that can be exploited, to continue to violate health-related human rights, continue to refuse to provide necessary information, just that continuous thread. Haikuanza na COVID, that's our point. That is the point of the real pandemic. And so the real pandemic is actually the constant human rights violations and lack of transparency and accountability on the part of the government.
You put it well, you phrased it well, and you given it a nice tag, the real pandemic. Okay, now we have the real pandemic. Then what?
Yeah, so now that is, I guess, the question that we all ask ourselves in any space or any human rights space. We identify an issue and then what? And so coming from maybe the formal NGO perspective, we do tend to follow now what the law says. So when there's an issue, if you want more information on it, you'll request that information. Then, send that to the relevant duty bearer, the relevant government body, hope for a response, there's non-response, send a reminder, again, non-response, then eventually lead to probably a case in the court.
You're an advocate you're an advocate of the High Court of Kenya, correct?
Technically, I'm a lawyer. I have yet to be admitted to the bar.
Okay, so technically you're a lawyer. That's good enough. Advocate of, those are details. But let me ask the question. Do you feel that as an advocate, when you talk about trying to fight this huge demon of corruption, as we keep calling it, do you think, or do you know, or do you believe that our courts are a reasonable or a good ally in this fight against corruption?
So I think the courts can be a good ally, but again, the courts do not work in isolation. And so a trend we are noticing, yet another trend to do with the real pandemic, is even when the courts have given very positive judgments, and there have been a number within the right to, around the right to health. So we've had court cases around, detention or treating, defaulting on TB drugs as a crime, had cases around sexual and reproductive health information. So the courts do make positive judgments around the right to health, even around probably information and transparency. The problem is whether the executive and the other arms of government then implement. And so the court can only be a watchdog in a system that's respecting the rule of law. So we've had many, many instances of cases. One, I think a very good example is around TB. So the pre-2016, people with TB, if they stopped uptake of their drugs, could actually be arrested and charged with a crime. And so once you're arrested, charged, and jailed, you go into, we have a general idea of the state of prisons. You're not put in isolation, you're not provided with adequate nutrition that you require, for those TB drugs to actually work. You may not even get that consistent prescription of drugs. And so the court actually decided and directed that crime, part of summing that as a crime, is unconstitutional, and directed the Ministry of Health to set up an isolation policy, a rights-based isolation policy, and, implement it. And yet in 2020, when the pandemic or when the first COVID case was confirmed in Kenya, you felt like government was scrambling, like, kuna kitu ka isolation, how do we do it? They're scrambling to come up with policies when there were previous directives by the court that could have built a base so that there's a more coherent response.
I mean, it's with all these things that are going on, because throw a stone and it's going to land on something that's going wrong, right? In the health sector. And then it would appear that very little is being done about it. And I'm racking my brain trying to think about what has been a problem that has been presented and that has been dealt with and that has been sorted out within the health sector. Can you think of one that is now running well and we can say, okay, here is an example of how something has gone wrong. You look at the systematic failure, then you fix it and you say, this is how now others can emulate and say, all right, let's do this, so that it can then contribute to a kind of point system in the health sector now that we say is functioning properly. Whether it's corruption, whether it's, Do we have any examples of such from the work that you've done for us to be able to look at and see?
Okay, so I'd say a great example is communities of people living with HIV. So KELIN, even at its start, dealt mostly with the rights of people living with HIV, and then now expanded into other health-related human rights. And so in the HIV space, pre-2010 or around the 2000s, there was a lot of stigma against people living with HIV, which has not completely ended, but it was much worse at the time. So you found the human rights of people living with HIV were really sidelined. Their rights to privacy of health information not respected. So people reveal their positive status, they lose jobs, they lose housing. In the cases of even women in Nyanza, there have been cases of constant disinheritance where their spouse has died of HIV. So they'd be told, the family would sort of imply that Alileta HIV, this woman that brought HIV to our son. And so that combined effort of civil society organizations, but also led by communities of people living with HIV, actually did lead to some gains. And so we saw things like the institution of the HIV and AIDS Tribunal that specifically deals with violations of HIV-related rights. So having expanded access, or rather at the time, expanding access to antiretroviral therapy. So there are instances where I think that's the core of it, where stakeholders work together and communities that are affected by the issue are centered, then there is progress. You can push towards something. And so the situation for people living with HIV in 2000 versus in 2021 is different.
As we talk about all these things and what's happening in the health sector, and you advocate for proper governance of our health sector, and this is what you push for, right? You've gone into the issues of financing. You've gone into the issue of the proper management of health systems and all. But then the other questions that keep coming out left, right, and center is on human resource for health sector, human resource for healthcare. Doctors, we don't have enough doctors. We don't have enough nurses. Yet we have very many who get trained, and not all of them are at work at all times. So the big question here is, how do we move and campaign such that those who have been trained in the country are able to be absorbed by the health sector in the country? What's required according to you and the work that you do at KELIN?
Yeah, so first off, you bring up a very good point. Human resources for health are a key building block of, a strong health system, and we've definitely seen it within the Kenyan context. And so I think the thing with human resources for health is there are multiple things that are required to ensure that, there's a strong, trained base of healthcare workers. So certain issues that come up consistently with human resources for health, first is the use of community health volunteers and advocates. So these are sort of community resource persons who do things like follow-up on HIV treatment, follow-up on TB treatment within communities, and they do a lot of the groundwork to ensure that people with chronic illnesses and chronic conditions are accessing the treatment they need. But having them sort of recognized as a formal part of the health sector has been an issue. And so there's currently a community health bill in place, but we see how that goes. But even beyond that, I think we're all aware of the extremely prolonged strike by nurses and clinical officers, and this is a continuing thing. And so for human resources for health, there's that need first off to recognize the different cadres, but also ensuring each cadre is, well taken care of. And so our key complaint of nurses has been that they do a lot of the actual work, like they do the real work of interacting with patients, but this is rarely ever reflected in remuneration, in insurance, in that sort of thing. There are even studies that have been done to show that nurses and clinical officers are actually sidelined when it comes to involvement of healthcare workers in healthcare policy making.
You know, City, as we're talking about this, the fact that there is an organization that is actually raising such an issue, the fact that we have such a hashtag, the fact that we are sensitizing and mainstreaming issues of we need to focus on what needs to happen to our healthcare system. We talk about this on this show all the time. We talk about this here every so often. We're like, you know what? Something needs to happen. Now look at KEMSA. This is looking at how to actually supply medical supplies to health facilities across the country, purchase and all. When there's an issue at KEMSA, investigations are ordered. Investigations take forever to be concluded. The action that's taken by the president and the health minister is to rejig the board. How far would this go? I mean, you don't get to a point where you ask yourself, okay, why are we behaving like there's nothing? I mean, like everything is normal. Like the best we can do here is remove the chairman of KEMSA from this board, take him to another board, remove the members of the board, bring in others, suspend the CEO, fire the CEO, bring another CEO. Who is it? Is it procurement head? Okay, just get rid of the procurement head, put another one. Does that address the issues really?
Removing them, if it only ended there, then you would say, well, there's a semblance of something being done. But these people are then taken elsewhere.
To go and carry on the misbehavior somewhere else.
So that's what raises the real issue. There are those who have said that we've actually normalized corruption. Actually, it isn't corruption that we've normalized. Corruption is an outcome. It's a consequence. It's impunity that we've normalized. Because corruption happens because people know they can get away with it. So this was actually what I'm saying is leading to what I want to ask. How would you like us to refer to you as Lisa?
Wakili.
Lisa is fine.
Justice. Lisa is fine.
Lisa is perfect.
Okay, Lisa, does KELIN have a program that seeks to address some of these issues or find a working relationship with the Kenya Police Force? Or service, they're called. Sorry, force, service? Do you have a program? Let me explain why I'm asking.
All right.
At the level of implementation, our police service is supposed to be independent, unless I get it wrong, is it not?
It is.
It's an independent police force.
Yes.
Sometimes we blame the police for things that are actually beyond them. Now, one of the things that KELIN does very, very well is they raise awareness. They make you aware. I know of the work that you've done with rights of widows, rights of women in land issues and so forth. I know this. But what about, because at the end of the day, our police service, the individuals who serve there are just citizens of Kenya like everybody else. Now, do you think from a position as somebody who works in KELIN that if you took the time, or if you've already taken the time to form a relationship with the police service, so that the very same thing that you're doing to other sectors of the public, you do the police, do you think it might bring about change in the attitudes of how the police go about their work? Because the police are often blamed as also being a bottleneck when it comes to justice being seen to be done.
Yes, very, very true. And so the thing with police is we have worked with police in the past to try to, especially with regards to violence against women, or sexual and gender-based violence and sexual and reproductive health. And so within our sexual and reproductive health rights work, we identified an issue with police officers, the way that either women who report an SGBV case are treated within the police station, or alternatively, when perhaps it's a woman who has been accused of procuring an illegal abortion. And so we have worked with police officers in the past to sort of sensitize them on, how to handle these victims and how to handle even if it's in the case of an alleged abortion, if someone is being arrested, still how to make sure that arrest is facilitated with dignity, that they can still access healthcare. And so the challenge with working with police is it's hard to form relationships as things are constantly changing. So we've had many situations where with trained people or built relationships, especially with the gender desk, then this person who you formed a relationship with and trying to forward work is then transferred. And so there are always opportunities, of course, to work with as wide a base of stakeholders, but then again, with opportunity comes the challenge of engaging them as well.
You know, we have had very many conversations here, and someone is saying, highly doubt in systemic impunity and manipulation from who is who, depending on whose interest one is protecting. Highly doubt any changes can actually come to our health sector. Lisa, we want to thank you very much for joining us and for speaking to us today. This is a good conversation. It's a good hashtag that you've launched. It's hashtag the real pandemic. I'm sure you'd like people to participate with in this conversation. So how would they do that?
Yes, so if this is going to be a running campaign, or you can follow it on KELIN's social media pages. There are also a number of other civil society partners. Zalendo Watch that does parliamentary monitoring, Transparency International Kenya, working in transparency and accountability, Haki Jamii, and People's Vaccine, which is a people-centered campaign for free, equitable vaccine distribution in Kenya. And so we'd really encourage people, because people have had experiences with the health sector. You know, it's not just civil society that's affected, it's actual communities, it's actual individuals. And so encouraging them to actually visit the tag on social media platforms and share their stories. Were you able to access health services during the pandemic? But even pre-pandemic, what issues were you facing in trying to access health services, in having those health services made available, in their affordability? So again, even inclusivity of vulnerable and marginalized communities. So people with disabilities, people living with HIV, people with chronic illnesses, having these, all stakeholders, having patients, having the public contribute to that tag, the real pandemic, to actually highlight what sort of violations or situations have they been within the health sector during the pandemic, but before the pandemic as well.
Very good conversation. Hashtag the real pandemic. Join that conversation. Share your experiences. Share your thoughts as well on what needs to happen to reform or improve access to healthcare for all. This is a constitutional provision. It's one of those rights, man, that everybody has a right to accessing the best health services at all times. Lisa, thank you very much for speaking to us today. Have a lovely day.
Thank you for having me.
This is The Situation Room, the only way to start your day.